Там у нас, я так понял, доктор Хедж подключился, да? Ну, давайте его.
So, Ilgor made some very important points, and this was just to talk about our Indian experience. Now, we all know that instrumentation in spinal deformity started about 60, 70 years back, and Harrington instrumentation was considered the gold standard. But was it really the goal to doing all did the standard posterior surgery with using pedicle screws, and this was the standard of treatment, or has been the standard of treatment even now. And we know that anterior approaches to the spine steadily reduced over the last 2 or 3 decades, and this was primarily because of a belief that amongst very senior respectable surgeons that posteriors was better, and also most orthopedic surgeons were familiar with the posterior approach. But some of us who spent time with legends like Professor Jürgen Harms and Klaus Zielke in Germany, we were trained to treat deformities, also look at anterior surgery, like in this patient who had a very severe deformity. Here you see the patient has a primary severe rigid thoracic deformity with a counter curve in the lumbar spine and a counter curve in the upper thoracic spine. Traditionally, this would be done from the back, which would mean D2 to L4 and a thoracoplasty, as well as PSOs at multiple levels. This would mean a blood loss of more than 1,500 ml. But we were able to do this because of our training, selective anterior surgery for the main rigid part of the deformity, and correct it and allow spontaneous correction to happen below and above and get an excellent result. So this is what was also described by other leading surgeons who talked about saving levels when you did anterior surgery as compared to posterior surgery. And we presented our experiences where we could show saving of at least 2 to 2.4 levels in our series. And we know that to date, the surgical goals for patients with AIS, especially when they are skeletally mature, for say 40 to 50 degrees, we tend to treat them with, we tend to wait till they become more severe. But we have newer modalities of treatment, and we can look at doing different options. Now we know that bracing was used for most of these patients early on for their deformities, but the results of bracing were not very good. The failures of bracing were very high, and most of these patients had to be finally instrumented. So our treatment is based on the assessment of the curve progression, that is the degree of truncal shift, the rotation of the apical vertebrae, the skeletal maturity, and the clinical deformity and the curve progression. And we know that, as was mentioned earlier, that non-fusion anterior scoliosis. I was mentioning that bracing, especially in our warm country, has had very poor acceptance with our patients. So what non-fusion offers is that it works as an internal brace, as Dr. Ilgar had mentioned, that it works on the Heuter-Walkman law and helps to maintain the correction, and the complications are minimal, and there are no detrimental long-term side effects that we have seen. So we started also as a growth modulation, that is the classical VBT. But the word tethering in English has a very inert connotation, and it means only to hold the deformity but not correct the deformity. So when we had the child like this with the Research 0 and the Sanders 4, with this deformity, and as Dr. Ilgar suggested, we undercorrected the deformity, and over the years, at 2 years, you can see her spine has become straight. She has a beautiful sagittal profile, and on the right side, you can see her clinical picture. She is holding well. Yes, of course, in the long term, the tethers may break, and that may be an issue that we have to wait for a long-term follow-up on tethers. Here we have a 13-year-old child who had a gradually progressive deformity. They had tried a variety of yoga and exercise treatments which had not worked. As you can see, she has a very severe lumbar deformity, what we call as a Lenke 5CN. And she had an apparent limb length lengthening because of the pelvic obliquity. Also, she had an incidental spondylolisthesis at L5S1. Now, you can see here on the left side, she is reasonably flexible. What would be the standard options? The standard options would be posterior fixation from D8 to L5. But if you stop at L5, you have to worry about the listhesis at L5S1, which may. So you may want to go to the pelvis. But that in a child who is a dancer, this would be a big issue. And the parents were not at all keen on standard posterior fusion surgery. We did a non-fusion correction of the main lumbar deformity. She has held well at 1 year. There is a slight increase. There may be a suspicion of the tether breakage. Here you see her pre-op, immediate post-op, 1 year follow-up. At 2 years, she is reasonably well. And her sagittal profile is also holding very well. And here you see her doing the traditional dance, and she is able to do extreme bending, which perhaps a child who would have been fixed into the pelvis may not have been able to do. This is another child. The important thing about non-fusion is that they are so comfortable. This child comes 3 days after her lumbar spine has been fixed, and she is so flexible. They don't have the kind of pain that most posterior fusion surgery patients have, and they are very, very comfortable. And of course, the blood loss in this surgery is minimal. And this same child at 1 year is holding well. This was done right in the beginning of our experience with non-fusion. Perhaps we would have gone one level lower in her case if we were to do it today. But at 2 years, she is still holding well. There is some increase in the curvature, but we do not suspect any tether breakage. Perhaps in Indian patients, lighter patients, we may not see early breakage of these tethers. So we now recommend that we should intervene early rather than late. Like you see in this child, in November 2021, she had all the signs of progression of deformity in a classical lumbar scoliosis. And you can see that in 6 months, she has gone from 35 to 44 degrees. And in October 2022, she was 55 degrees. Having the tether now, we would rather intervene earlier rather than later. Of course, we did a correction and she has had an excellent result. But this is what we recommend. In light of our experience with non-fusion, we recommend that when we see these deformities, we do not have to follow the traditional rules of waiting till the deformity progresses to 45 or 50 degrees. We can intervene when they are even at 30 or 35 degrees. As we know, as this study which was presented recently in the Scoliosis Research Society meeting, all these deformities do tend to progress. And in the long run, we now know that if we were to intervene earlier, it is better. We have presented our experience, and it's now coming in the Asian Spine Journal, our 2 to 5 year experience. And we are happy to say that we have had, though complications have been reported with anterior surgery, we have not seen any thoracic duct injury. We have not had any atelectasis or ureteric or incisional hernias or even vascular types of injuries. So this technique in surgeons who are comfortable with anterior spine surgery, it has very low level of complications. And as Dr. Yilgar suggested, that this would be a good option in some of our patients, and we can use it to get good results. Of course, long-term has to be followed. And once we know, why would we use a specific technique when we know that the natural history of a condition is undesirable and the patient's deformity is going to progress, and the intervention alters this natural history in a favorable and reproducible manner with minimal complications, and the long-term side effects of the intervention are not detrimental, and we are not burning any bridges. We can always intervene, do in the small number of patients in where the tether may really fail and the deformity recurs to a significant extent. That small percentage of patients may require posterior correction, but most patients will be happy with the correction that they have. And this is a very good way to and a new option to manage deformity in our young children. Thank you.
Dr. Hedge, I have one question for you. What kind of system do you use? It's the first question. And what kind of system do you use for dynamic correction of the instrument? What kind of instrumentation? Yes.
Unlike the Turkish experience, we prefer to do mini open, and we actively go to correct segmentally. Like in the olden days when we were doing anterior fusion surgery, we actively correct the rotational deformity as well as the coronal deformity. And the system that we use is the Globus system from Philadelphia. This, now we have the availability of a thicker cord, and the screws are hydroxyapatite coated, which get long-term fixation in the vertebrae. The closure mechanism is of a very specific type, which does not put strain on the screws when we close on the tether. And I think it is an important factor in preventing the frequency of breakages of the cord.
Do you always use only one screw in the vertebral body, or in some cases?
So I did not show, Dr. Kolsov, I did not show our elderly patients or older patients. In the older patients, in the bigger patients, we prefer to use a double cord. But now we have started using a thicker cord, which is about 2 millimeters thicker than the older cord. And we hope to see less breakages with that.
Thank you very much. Thank you very much. Stay with us. Следующий доклад Роберт Мэвес. When